Welcome to Cancer in Our Community, where we have conversations about care for members of the Black and African American community. My name is Dr. Brandon Blue. I'm an oncologist in the Malignant Hematology Department at Moffitt Cancer Center and your podcast host. This episode comes to you during June, also known as Caribbean American Heritage Month, a time to honor the achievements and contributions of Caribbean immigrants and their descendants living in the United States. In recognition of this, and more specifically, the experiences of our Haitian community members, we're excited to be joined today by Dr. Clement Gwede and Dr. Dorothie Durosier Mertilus. How are you both doing today?
Doing
Fantastic.
great, and you?
Thank you.
Listen, I'm so excited to have you both here today, and really, we're going to dive into talking about more of the work that we do. But before we do that, I think it's important for us to really introduce you to the audience, okay? So we're going to do ladies first, okay? Hopefully that's okay.
Absolutely, no other way.
Wonderful. So first up, Dr. Dorothie Durosier Mertilus has a Bachelor of Science, a Master of Science, and a Doctor of Nursing Practice degrees. She has a lot of degrees, well-educated woman. She has earned a PhD in nursing science from the University of South Florida. She is currently employed as an APRN with over 5 years of clinical experience working with patients in the Malignant Hematology Clinic at Moffitt Cancer Center. She also is an associate professor at the University of South Florida College of Nursing. Next, we have Dr. Clement Gwede, a senior member in the Department of Health Outcomes and Behavior, Division of Population Sciences, Cancer Prevention and Control at Moffitt Cancer Center. He's also a professor in the Department of Oncologic Science at the University of South Florida College of Medicine. Dr. Gwede's research interests, expertise includes reducing cancer disparities among high-risk, medically underserved, multi-ethnic, diverse populations, and improving quality of life for cancer patients during treatment and during survivorship. Whew! So, the both of you got a lot of letters behind your name. You both have been in school for a very long time.
I'm tired.
It really just shows us how educated you are, how qualified you are, how dedicated you are to really doing the task that you do. So I'll just start with Dorothie, because I do want to make sure that this is important, that people, the listeners, understand. I use the letters APRN. Can you explain to the people listening, like, what exactly is that if they're unfamiliar?
An APRN, or Advanced Practice Registered Nurse, is a nurse who has obtained at least a master's degree in nursing and has advanced clinical training beyond that of a registered nurse. APRNs are prepared to provide a high level of care, often specialized in family care, oncology, or pediatrics. They are equipped to perform assessment, diagnose condition, interpret diagnostic tests, and initiate treatment plans. APRNs include nurse practitioners, clinical nurse specialists, nurse anesthetists, and nurse midwives. Each of these has a specific role, but they all contribute significantly to the healthcare system by providing high-quality, cost-effective care, often in collaborations with physicians and other healthcare professionals.
Whew, so it sounds like you keep yourself busy. That's what it sounds like.
Yes.
Now, Clement, I want to talk because you also have a lot of letters behind your name. PhD, MPH, RN, FAAN. What is all that?
So let's start from the beginning, because we both share, and thank you, Brandon, for hosting this podcast. We both share the nursing background. So I did the registered nurses training, and I stopped there in terms of nursing education. I didn't go to the master's. I didn't go to a PhD in nursing. So my PhD, my master's in public health, and other training are in public health, which focuses on the idea that as a nurse, I work one patient at a time, right? This patient right here with this problem. In public health, we try to take knowledge that we know and benefit the whole population. So PhD in public health, Masters of Public Health, and the FAAN is a fellowship of the Nursing Association. So just a recognition of the contributions and impact in nursing.
So what I want our listeners to understand is that we're listening to some very smart people here. All right. So this is really people who are dedicated to understanding the human body, and really they've really developed their lives to not only teaching but also research themselves. So I think this is going to be a great conversation. So I really do appreciate you both for coming. Okay. Now that we got the introductions out of the way, I think our listeners have a really good understanding of, kind of who you are, at least on paper, right? But maybe some of the nuances of exactly what you do, I think need to be delved into a little bit more. So let's start with you, Clement. So you use the word health equity, public health, in a lot of the things which you were describing. Some of the cancers that I know that you tend to work with a little bit more tend to be colorectal cancer or even prostate cancer. But can you tell the listeners, what do you exactly do with those cancers, and how do you try to improve public health for that?
No, fantastic. So the whole goal of my work is to take the knowledge we know about preventing cancer, detecting cancer early, and leading people into early treatment when cancer is curable. So my lab works on understanding what works to get people to engage in both screening and early detection, but as well as clinical trials, so they can access the best quality that there is based on the scientific knowledge we have. The challenge, though, is that we have many discoveries in public health, in nursing, and in medicine, and in other science, but they don't percolate down and get accessible to the general population, particularly individuals who are uninsured, immigrants who may not be well connected to the health system. So my work is trying to get these benefits, these discoveries, these established modalities to all people, including immigrant communities. And my work is trying to really give them access and connection to the system so they can benefit. So we can address the gap we see. We see a huge gap that if you look at colorectal cancer, we, in terms of mortality and benefiting from the health system, all racial ethnic groups generally started about the same place because we didn't have screening modalities. When the modalities came up, blacks started to trail behind, for example, whites. So that gap has been maintained for a long time, and we're trying to shrink that gap.
Got it. So what I hear you saying is that there are people who have the same exact diagnosis, whether it be colon cancer or prostate cancer, but unfortunately they die at different rates.
Yes.
And so we were fortunate enough to actually have a screening process. So typically there's a couple for colon cancer. People could either they could test your stool for colon cancer. They could actually do the procedures such as the colonoscopy. And even for prostate exams, there's prostate cancer you can detect either from a digital exam or even they do the screening, what they call the PSA check. But why is it? Like if you're saying, hey, there's certain groups of people who just aren't getting this screening, why are they not getting that screening? If it's available, why are they not getting it?
Those are the inequities we see in the system. What we try to do in my lab is bring access to simple tests such as this one, which is a home stool test collected at home and sent back into the health system, and you get a result. Mm-hmm. If it's abnormal, you get connected to a colonoscopy to follow up to complete your testing and determine if you have cancer or not. The reason why is complex, just like why certain groups of people cannot get loans from banks or get a better rate in the interest rate. In this regard, some of it is awareness on the part of our communities. We just are doing other things and are less aware of the modalities that exist. But some of it is true barriers to the system that doesn't pay attention to our needs, that does not make it easy, does not make it accessible. So rather than spending a lot of time on the why, which is historically a big question, it's associated with how our system is set up, our unequal system, we spend time trying to say, how can we bring it to the people for tests that are simple to do, that are affordable. Health insurance is a big deal. The Affordable Care Act has helped a lot. There are a smaller percentage of individuals that are uninsured than we had before the Affordable Care Act. We went from about 39% in our communities uninsured to now a little bit 20% or below. So those are some of the approaches that are helping, but at the end of the day, people need access to care and they need help to benefit from what we know works. We know colorectal cancer screening works. We know finding prostate cancer early works. We know those two diseases are highly burdensome in the Black community. So we are working to address that.
So what I hear you're saying is, let's make it easy.
Yes.
So let me give you an example that we learned in medicine that we actually got from the business world. So what used to happen is that you used to go to an ATM, you would put your ATM card in there, and then what would happen is that it would give you your money, and then you would take your card.
Yes.
Well, what they learned was that people would take their money and forget their card in the machine. So what did they do? They actually says, before your money comes out of this machine, you got to take your card first. They made it easy for people to be able to still get the money, but not be a threat and leave their card in the machine. So it sounds like through some of these options that you just made available, we can actually make screening for cancer so easy. You may not even have to leave your house. Is that what you're saying?
Yes, you'll be able to collect it in your house, mail it out. In most cases, the new thing we see on the TV, Cologuard, is mailed to you. You collect it in your house, you mail it back, you send it back. Your only next visit is to receive the results or to do the next steps if it's abnormal. So we're making these modalities accessible, they're making them affordable, and they make sense to do.
Listen, I think that if you hadn't heard it before, you've heard it here today, that we're really trying to spread the awareness and let people know that you can do this. You can get screened for cancer, and we're really trying to make it much easier for you day in day. Yes. But I do want to switch the focus a little bit to Dorothie. So, Dorothie, I know that you have a lot of experience actually with patients and seeing people kind of bedside and nursing and really kind of taking care of people in the clinic. But you also do research, right? Yes. And so I want to just talk about how you are able to incorporate research in your nursing, and really what do you use as a way to like do that, or how do you even do that? Or are you the only nurse that does research? Or like talk to me about how you even do what you do.
For me, I know, like just like you said, I do several things because I like to be focusing on several things, so I get busy. And for nurses, it's increasing, like very common for nurses to engage in research, especially when they have like an advanced degree. Nurses play a vital role in healthcare research, contributing valuable insight into patient care, clinical practice, and healthcare systems. In my case, I feel like my practice informs my research. Like based on what I see, like any symptoms that the patients, if I see they got the common symptoms, what I do, I try to see what can we do. Can we do something to diagnose it better, assess it better, or manage it better?
So tell me a little bit about that. Like, how do you talk to a patient and maybe notice that they're having certain symptoms, but how do you turn that into research? Like, how do you study that?
Or it's just like I see the problem, and then I go to the literature, and then kind of turn it into a research question and see, is there anything? If there is something, the thing is with me, I got both a PhD and a DNP. The DNP, I put evidence into practice, and the PhD, I generate like the science. And like if I see there is a problem, the first thing is to go to the literature and see, is there anything that already exists? And if it does, are we doing what they recommend? If not, you try to put it into practice to manage the symptoms and make the patients feel better. But if there is nothing about what I think could benefit the patients, then that's when I got the background and see there is a gap in the literature. And then from there, I generate the questions and start developing like my research plan and then carry the research.
You know, I think that that's important. So I just want people to understand that the way that things typically go is what we call bench to bedside. And what that means is that typically there's a scientist that thinks of something, and then it goes forward, and we use it as the doctors at the bedside. But it sounds like what Dorothie is doing, she's actually doing it the opposite way. She's saying, hey, I'm noticing these things at the bedside. All of my patients are having this problem, and there's no literature out there, nothing in the books that tells me why this is happening. So you actually go back then and research it and say, hey, let's get to the bottom of this and let's figure out how we can help patients better. Is that what I'm hearing?
Yes. Anytime I see it, I have to make sure that did someone already generate the science? And is it because it's there and we're not translating the science, just like into practice? And the beauty of that is I got a doctorate degree in both nursing practice as well as the nursing science. And like if I see the evidence is there, if we're not using it, you can do an evidence-based practice project and make sure that we translate the science that they have already so it can become available for everybody to use what they have. But if they don't have it, then I try to come up with some research questions, and then with that, I can help generate the science because there is nothing available about it.
It sounds like you are really writing book chapters and doing everything. You know, you're really advancing the field of medicine. I mean, this is really what it takes, right? Because medicine always needs to grow. You know, it's like a flower, you know, and so we need to continue to plant deeper roots and continue to let this flower of medicine grow. But the only way we do that is through medical knowledge and really through some of the science and the work that you're doing. So I really tip my hat to you on that. But I want to just take a step back and dive a little bit deeper, okay? Because I know that the both of you like to work with what we call marginalized communities. You both like to work with people who are what they call the frails of society, whether that be people who may not have enough money or people who might live, you know, in what we call rural parts of the world, or people who might come from different countries, you know. Why is that important to focus your research and your efforts on that type of community? Clement, we'll start with you.
Yeah, no, that's a fantastic point here. So I like to say my library is in the community as opposed to the Moffitt Cancer Center Ivory Tower. I go to the community, meet the people where they are, understand the problems in the community, develop solutions with the community. So let me give you two quick examples. And you and I have done programs that are similar in the community. In the area of colorectal cancer, we did several projects that involved the Caribbean community, blacks from all over the world, and we called it I-ACT, meaning act now, do your colorectal cancer screening. And that project was recruiting people in barbershops, in churches, and giving them access to this simple, low-cost screening tool. And in that regard, we were able to get people to take this home. We met them in the community, take it home, send it back to us, give them the results back, and help them get access to a colonoscopy if something was abnormal. So working with the community, with advisors from the Haitian community, Caribbean Community Association, several organizations of the Haitian background, including Haitian Association Foundation of Tampa Bay. And we were able to be really successful and have people, do the tests. A few were diagnosed with cancer, and they were linked to care here at the Moffitt Cancer Center. Another example of working in the community and going where the people are is working with federally qualified health centers, which is a group of clinics that delivers care to underserved communities, including rural parts of the counties, inner city parts. And in those systems, we work with the whole system to make these kinds of tests available to their patients. Even though they are receiving care, they are focused on primary care. They're not focused on prevention, screening, and early detection. So we work with them in their environment to try and boost screening rates and benefit the patients, but also address these disparities that we're talking about.
But when you go into the communities, Clement, what do you say to people to make them trust you, right? Like the biggest thing is that this guy doesn't know me, or they may have never even heard of Moffitt, so they may not know about all the wonderful things that we do. So what do you tell people to say, I need you to trust me and I'm here to help?
Absolutely, and we know the historical background to the healthcare trust and mistrust, right? So what we try to do is work with leaders in the community, the pastors, the organizational leaderships who are sort of the cultural brokers to say, trust this guy, trust these people from Moffitt, trust them that they are interested in doing science that will help your community, not science for science sake. That will be in books and book chapters, you said. So when you work with the community leaders, community members also who are part of a community advisory group, then they are able to shepherd you and they help you address a problem of importance to the community. Not just something that we want to do as a cancer center, but a problem that is important to the community. Similarly, we work with the clinic leaderships. They say we are working together with Moffitt to do this project. So it becomes part of a trusted partnership, trusted relationship, and most importantly, we work on focusing on making sure that people benefit from participation. So there's a real care being delivered. So there's real tangible improvements that we are trying to achieve. I think we've really done this historically for almost 20 years, that now is part and parcel of a relationship, not sort of helicopter medicine where we come in, we take what we need and we run. This is more, we are here to stay, we are working together, it's a partnership, it's a collaboration, and it's benefiting our communities and specifically individuals.
I think you touched on something that I want to just make sure people heard. When Clement and his team is doing this research, they're not just doing research for research's sake, but they're doing it to actually help people. And I think that's what people need to know, is that this is research, yes, but it's helping you, it's helping your children, it's helping your grandchildren, because we're learning more and more about these cancers and how to prevent them.
Yeah, and to deliver things that we know are beneficial. We are not testing things we don't know. We are testing, can we do this to improve the rates and screening for early detection of cancer?
Because I think we all are really trying to not only just find the cancer, but we're trying to cure it as well.
Yes.
And so, Dorothie, I want to talk to you. Why is it important in your particular case to work with certain groups of people?
Like, for me, mostly I participate in several health fairs throughout the community, and I work very closely also with the community outreach engagement department here at Moffitt. We also, I think last month, we had like the mammogram bus that came at my church. And this way, it helped better. One, a lot of people, they don't have any health insurance. They don't have access, even if they would like to do it. And another thing is sometimes they do have health insurance, but life is busy. And sometimes you got good intention, but you cannot do it. But when it's there, one, it's convenient because some of the people at my church, they had like health insurance, but they still went, like it was on Saturday, day off on Saturday, especially like when you're Seventh-day Adventist, you try to get like the one day, if they're going to give you one day, Saturday you try to get, that's when you might want to go see like a healthcare professional, but you don't have the time. To be able to bring the bus at the church, then they get the mammogram done. And we also see like sometimes we do health fair, we have at least 3 people that needed to go to the ER right away because it's either they were in hypertensive crisis, and we got some of them, they got like some chest pain, and this way you go to the people, and when you go to them in this way, it's more convenient for them, and you make sure that they get the best care possible.
Well, I'll tell you that if you guys remember at the beginning of this episode, we talked about this specific episode is really dedicated for Caribbean American Heritage Month. And so now, Dorothie, I know that you are of Haitian descent and you speak both Haitian Creole and French.
Yes.
Now, parlez-vous un petit français myself.
Okay.
But I do wonder, when you're out and doing these things and talking to patients, does that help you? Like, are you able to connect more? Or do you find people who are of Haitian background when you're out there doing things and you can kind of relate to them on that way? And then also, too, like, how do you incorporate that into any of the research that you do? Does that give you maybe any different perspective when you're out here trying to answer some of these questions?
Yes, thank you for the question. Yes, certainly. Being of Haitian descendant and speaking both Haitian Creole and French helped me to connect with the people because they know, like, even if I try to, before I go to the community from where I work, like at Moffitt in the clinic, you will see, like, when I see the patient, I try to say their name in French so they can kind of get like a hint that I speak, and sometimes they don't say anything. And then they start speaking with me, and I see they got some things they want to say and they cannot come out. And as soon I speak Haitian Creole or French, they start. Now they couldn't, everything was fine. I said, are you okay? Mm-hmm. Everything was fine until you start speaking the language. Now they can tell you what how they feel, what are their concerns. It's just like when you have someone who, like understand your culture, who understand your language, you feel more at ease. And you can see like when we go to the community, sometimes I go to other Haitian churches, but they don't know that I speak Haitian Creole yet, but I go like either to be like a faculty, a advisor, just like to kind of be there for the students at USF. As soon they come to me and I start speaking Creole, oh my God, now they can tell you everything. It's just this way, they got the trust too, when they can see you got the same culture. And when you tell them the thing, like at church, I know if I want something to be a success, I have to start early. Just every Saturday, I have to keep doing it. And one thing I saw, to sometimes they want to do something like for the mammogram, they wanted to kind of like register, but if they don't understand the language, they cannot do it. But when you're there, they cooperate more with you because they know you understand them and you show them that you're there for them. It's not like the other people, they're not there for them. They know that, but can they act? They don't feel comfortable just like to go and ask.
But how do you use that from a research standpoint? Is there any way that you say, hey, when I'm thinking of some of these questions, let me think of people who may be from a different country, maybe from Haiti or from any place in the Caribbean. Like, do you keep some of those things in mind when you're trying to answer some of those research questions?
Yes, because even like if I want to get their perspectives, and I know like sometimes they don't like taking medications because I'm telling you, they love the tea. And even in the research, when you're doing it, you need to take all these things into perspective. What are their beliefs, the culture, and how can you get them to participate to see that the research will benefit them? Even if it's not them, it could benefit like someone else. It's just that you just need to make sure you take all these things into consideration, the culture, the beliefs, and all of this whenever you're trying to develop any research questions about them.
Which really brings me to the point that when we do these programs in the community, we also deliver our education in language they prefer, Spanish here, Haitian Creole there, English language, so that it resonates and is understandable in a literacy level that is plain language, so that not only do they have full awareness and understanding, now they can understand why it's important to do the screening and early detection that we are promoting and or delivering. So not only for insured people in the community, they also need the same information, and uninsured people also need the same information coupled with the access.
But tell me this, Clint. I mean, if you are out there in the community, we can't copy Dorothie, right? Like,
Yes.
we can't copy someone who is literally in their culture, speaks their language.
Yes.
Like, we can't have that at every time. And with so many different languages, with the importance of so many different cancers, like, how do you do that then if you're not, from Haiti? How do you reach someone who's from Haiti? Like,
Absolutely.
what would be the thing to do?
No, the thing to do is exactly this. We partner with someone from the community, whether it's a professional trained person like Dorothie or others who work in the Haitian community who are from there, and we either train them to achieve our goals, or they are already well versed about the topic, and we go through and work together to reach the people in a manner that resonates with their culture, their language, their preferences. And it's all about the trust that you started off with. We need to build trust by ensuring that if we reach out to you and excite you about getting screened for colon cancer, we have a place for you to go. We have a test for you to be able to do. If we found something abnormal, we will take care of you. We will link you to care. So those kinds of things over time creates trust, because people see if you engage in a health fair and they give you a test, they'll also give you the follow-up care that you need.
I think that's important, because I think some people are scared that, nobody wants to have cancer, right? Yes. And so if someone is brave enough, and we really appreciate our listeners for being brave enough to be tested, But then the next step is, well, what am I going to do about the result, right? And so knowing that not only can I be tested, but also I can trust that I can go to a place to actually take care of what might be there, I think that really gives people, a peace of mind.
Yeah.
But I also want to talk about these disparities, right? Because I do know that there is probably some challenges in the research that the two of you do that may be different than some of the research that, like you said, in this ivory tower that people who don't go into the community do. So can you talk about what are some unique challenges maybe that you would have working either with, a minority community or really doing health disparities research? What would you say would be the biggest kind of challenges that you come up with?
Like for me, I also take into consideration to make sure that we got a diverse population whenever I'm doing my research, but I do not focus for now in the community health, but I mostly work with developing programs in the community so we can make sure that the patient, they got the screening, and as well, if they need any follow-up, we got everything ready for them. And for me, the biggest thing is the access to care. Like for them to have the access, either from insurance, they know they're not feeling well, but they're scared about how much will they send me as a bill. And I'm already going through all of that even to pay my bills. Can I afford one more? And I feel that's the biggest thing. Like when I work in collaboration with Morpheet, where I can let them know, like if they said, I would like to get a mammogram, and you said, okay, if you don't have the health insurance, Morpheet will cover it. Also, we make sure that even when we organize, I work with Winnie, she makes sure that there is a coordinator just in case if there is an abnormality. What can we do just to make sure they get the access? And I think that's very big, and we just need to make sure we got more initiative and more community outreach so we can make sure that they get the best care possible.
No, that's an interesting question. What are the challenges working with the community? Several examples. One example is when we go out to talk to groups or individuals, we often hear things like, I'm not concerned about cancer because I eat very well. I'm from the Caribbean. I eat fruit. I need natural foods. And what we try to do in my area, as you know, Brandon, is to find people, have them be screened when they don't have symptoms, when they don't have any problems, when they are feeling well and healthy. So that's one big challenge because people think you do cancer screening because you're having problems. We want to screen you when you're feeling well for lung cancer, for colorectal cancer, for prostate, for all the screenings is when you are feeling well. Follow a schedule so we can detect things early. Your body doesn't speak to you very well. It's not an efficient, by the time you have symptoms, it may be too late. Most of these cancers are silent in their early stages. There are no symptoms to be observed or felt. So we want screening when you are well, screening when you are not sick, screening when you are, feeling healthy. That's one point. The other point is, I don't want to find out. Why go look for trouble? I'm doing just fine. And similarly to what Dorothie said, if I find something, don't have a way of taking care of it. So those are challenges we find. And then obviously the big cultural perspective about disease. In most communities, doctors are for fixing problems, not for preventing problems. So it's a bunch of paradigms or ways of thinking or worldviews that we have to talk through in order to say, change the way you look at this. Look at it as your preventive maintenance for your car. Men in our community spend a lot more time, money, and investment worrying about souping up their cars and doing all these things, and they don't think not a minute about their own bodies, about simple things they could do to stay healthy and ward off this advanced stage diagnosis. The reason why most of our people die is because they come late, the treatment no longer work very well at those stages, and therefore we continue to see these persistent differences or disparities. So that's what we spend time trying to understand. How can we help people change the way they think about prevention, screening, and early detection? How can we get people to come in early? How can we get people to take advantage of the scientific knowledge and modalities or tests that we know work.
So if we talk about worldviews, which is what you brought up, right? You know, this episode is really trying to target folks for the Caribbean American Heritage Month, right? So I would like for you both to think of maybe one thing for folks who might be in the Caribbean community and say, hey, I want you to listen to the whole episode. But if you happen to fast forward, at least take this one message home, you know? So I want you guys to think about that. So Clement, we'll start with you. Like, if you could think of, hey, I know you guys are listening. I want you to take this message home. What would that message be?
I think twofold. One, be aware, take advantage of the information and educate yourself about what is available in screening and early detection of cancer. Two, talk to your doctor about your plan for getting tested and screened for cancer. And three, talk to your family members so that they can begin to get the culture of screening and early detection when they don't have any problems or symptoms or when they are feeling well. If we can communicate about it, if we can share information, if we can advocate for ourselves when we go to the doctor, we are going to move and take advantage of what's available in the system.
Good. Dorothy, what about for you?
For me, one thing that I will say is just like, I know it's hard, like especially with the past history that they have. It's just like we come like many years after to trust the system. And if it's working for the other ethnicities, that means it can work for us too. When it's time for you to start your screening, do them because it does matter. One cancer, like is for example, like colorectal cancer, 91% early stage, and by the time you get to advanced stage, it's 17%. That means just like trust the system because it's working, and we know it's hard sometimes. Just like we already see several years showing us that it works. It just like get screened, and so we can prevent the disease.
Well, you heard it here from two wonderful, well-educated doctors who are just out there doing the work in the community, you know, and so this is really from their hearts, and really we want folks to not only just listen, but also take action as well. And so this is the part of the podcast where really I want to just make sure that we know that they're more than just very smart doctors and they're more than just smart researchers, but they're actually people, okay? And so I want to just find out something fun from the two of you, okay? So I know that you guys are out in the community doing your thing, and you guys have all those letters behind your name and teaching and all these things. But when you're not at Moffitt and doing those things, what does Dorothie do for fun? Like talk to me. And Clement, you'll go next. But what do you do for fun?
Outside of Moffitt, I enjoy spending time cooking.
Okay.
Yes.
But you came here with no food. I'm confused.
I know, but next time. Okay. That means I have to make sure that you can invite me another time.
Do you have a go-to dish? If someone says, hey, we want Dorothie to cook for us, what's going to be your go-to dish?
Oxtail.
Okay. All right.
Yes, oxtail. And I like to try new recipes and just like flavors in the kitchen. Like when it's trying out a new cuisine or perfecting a family favorite, they love for me to cook. When I'm cooking, you'll see everyone call, hey, the restaurant is going to be open today. They call it a restaurant, my kids. And it's just like, that's a way for me to express myself and also share delicious meals with friends and family.
I'm getting hungry. Clement, what do you do? Outside of Moffitt, what do you do?
I stay away from the kitchen. You know, Brandon, you're asking me a question that's quite interesting. My younger self would have answered this way. I like to play tennis. I like to play soccer. If it's a sport and it's not baseball, I'm in it. But my older self is, I can't do those things anymore. I can't chase that tennis ball as quick as I used to be. I've had a few injuries, so I'm now relegated to watching soccer. I watch the professional soccer, the English Premier League, the European Champions League, and all this. I'm a soccer buff all the way through and through, and that's my thing.
Well, listen, I just want to say I appreciate you both. Thank you. Thank you so much for taking the time to talk to us. I think this was a wonderful conversation, and we are really excited to have you both launch our season 4 of this podcast. To our audience, please make sure that you check our show notes to keep up to date with what's happening at the COE for the Office of Outreach and Engagement. And this is me, Dr. Blue, signing off from your favorite podcast, Cancer in Our Community. Thank you.
Thank you.
Bonjour, moi c'est Winnie Cajus. C'est un éducateur de santé dans Moffitt Centre de Cancer, location qui est Tampa, Florida. Bureau pam c'est COE, nous fait focus sur prévention dans la communauté. Par exemple, si tu as besoin de connaître plus d'informations ou soit besoin d'éduquer en qualité de cancer, ou toujours contacter avec nous et puis nous venons faire une présentation pour répondre à toutes questions ou qu'à gagner. Nous avons quelques activités qui viennent à ça. Nous faisons partenaire avec une organisation qui est les KL. Avec l'organisation ça, on a préparé 4 activités. Première activité, c'est 12 juillet, deuxième, à 13 septembre, troisième, à 15 novembre, et puis dernière activité, à 31 janvier. Et puis, nous avons une activité dans l'église adventiste Cap Vini le 20 septembre. Si vous avez besoin de plus d'informations de l'activité, vous pouvez toujours envoyer un email dans coe-office@moffitt.org. Encore, c'est coe-office@moffitt.org. Je suis bien content d'entendre l'épisode ça. Merci. N'a pas les plus tard. Bye bye. Hi, my name is Winnie Cajus. I'm a community health educator at Moffitt Cancer Center's Office of Community Outreach and Engagement, also known as COE. The following are some upcoming events where you can find COE out in the community, starting with a series of events sponsored by KYAL. The first event for KYAL is going to be on July 12th, 2025, the second one September 13th, 2025, the third one November 15th, 2025, and the last one ending on January 31st of 2026. We also have an upcoming screening event with the Salem Seventh-day Adventist Haitian Church. The date for that event is September 20th, 2025. To stay up to date on future COE events, community screening announcements, or to invite us to host a health education workshop or collaborate with your organization, you can visit our website, follow us on social media, or email us at coe-office@moffitt.org. We look forward to seeing you out in the community.